All right, let's go on to the next lecture. Won't take long, this one. It kind of, we're looking now at the cytology of these benign proliferative reactions. And I've already introduced you to some of it. Again, responses to external stimuli can be protective, destructive, reparative. Primarily, we're focusing in on the protective responses today. Thank you. Can you stick it in my stuff? Thanks. All right, the importance is that these cells can have an appearance that's different from normal. It's a variance, okay? We use the word atypia loosely here because I don't want you to think when we say atypia in the essence of something concerning for malignant or dysplastic, but basically it's just something other than typical normal, okay? So atypical, variance from the normal resting euplastic state. Now this recognition is essential to differentiate protective proliferative reactions from abnormal processes such as dysplasia and neoplasia. These are some of the protective reactions we just talked about: squamous metaplasia, HKPK, vaginal adenosis. The first one we're going to look at is squamous metaplasia because it's one of the more common that you will see. And let me clarify something as I was thinking about it earlier, just so to help make this less confusing. So basically there's a transition from endocervical to squamous cells. And that transition can involve this whole process. It can go from, first of all, you may see very earliest on some reserve cell hyperplasia, okay? Then they start to look like immature squamous metaplastic cells. Then they look like, when they start to get more mature squamous metaplastic cells. And then the most mature cell is just a mature squamous cell, all right, to make the distinction. So all the way from endocervical to most mature squamous cell. So you are going to be able to distinguish between squamous metaplastic versus mature squamous cell. Maybe that helps clarify it a little bit. So, again, squamous metaplasia is the most common reaction of the endocervical epithelium. It is not a precursor of neoplasia. Dysplasia is, but not squamous metaplasia. It is a changing or transformation of one cell type to another, and whereby the columnar epithelium is gradually replaced by a more protective squamous epithelium. And there are three stages, as I just went through, okay? Reserve cell hyperplasia, immature squamous metaplasia, mature squamous metaplasia, before it then actually looks like just mature squamous cells. Now, reserve cell hyperplasia involves one or more layers of this undifferentiated germinal type regenerative epithelium that lies beneath the columnar epithelium. We rarely see it on pap smears, but it is important to recognize, and these are the main features of reserve cell hyperplasia. The nucleus averages 50 square microns. It's round to oval. It's centrally located. It has finely granular, evenly distributed chromatin, normochromic, and no nucleoli. But these cells have a high NC ratio. They have very little, because they have scant cytoplasm, which tends to stain cyanophilic, looks finely vacuolated, and again, the cell size is between 127 to 175 square micron area, okay? So it has a very high NC ratio, usually. They can occur as syncytial fragments, where the cells can be overlying each other, and you can't make out their cell borders. And because of that syncytial arrangement, and because of the high NC ratio, it tends to mimic abnormalities such as CIS, which you'll learn about in the next module in much more detail. But here's the example again on histology, showing you some normal endocervical columnar cells on the surface, beneath which there are 1, 2, 3 to 4 layers of these very immature reserve cells on histology. Here they are on cytology again. Actually, I think it's a similar picture to the one earlier. It's just reversed. I think it looks reserved. But nevertheless, you've got a group here. You've got a few isolated cells here, but mostly you have a group here with some crowding, a little bit of overlapping to the nuclei. But the nuclei are small. When you compare these nuclei to the size of your size references in the background, your neutrophils, here you've got your superficial squamous cells, but these nuclei are, they're slightly large. They're definitely larger than as everything else is, definitely larger than the superficial squamous cell nuclei. They are larger than the neutrophils, which average 35 square microns, remember, your size references. So they're actually closer to endocervical cell size nuclei, but with very scanty cytoplasm. Now, and we mentioned in the slide earlier that they're cyanophilic. This stain happens to have an eosinophilic overall tinge to it, so here they actually look a little bit pale and eosinophilic. Now, in mature squamous metaplasia, the cells begin to show evidence of squamous differentiation. The nuclear features are similar to reserve cell hyperplasia, whereby the mean nuclear size is 50 square microns. So very similar, but what's happening is these cells start to take on a little bit more cytoplasm that starts to look a little, a little thicker, okay? Not as dense as a mature squamous cell, but definitely a little thicker, a little denser than a reserve cell. You won't see vacuoles in the cytoplasm. The cytoplasm might start to look a little darker, basophilic, and then there'll be more of it. So the NC ratio starts to get a little lower here as they take on more cytoplasm. Generally, nucleoli are not observed, generally. The cytoplasm I mentioned is more abundant than reserve cells. The cell size averages, and they're a little bit larger, obviously, than reserve cells overall. The cell size averages 318 square microns. And you guys will have to measure this and do these measurements, right?
Do now.
You took me for real, huh? Okay. I was just joking. You can if you want, I mean, think about it. How do you actually come up with 318 square microns? Who came up with that? Actually, there have been people in the past that have looked at just thousands of these cells and made average measurements, and that's where it comes from. So, but if you want to take the time to do that, you're very welcome to. All right. But I had you going there for a minute. I did it. I knew I did. Okay. Now I know. I actually see that you guys are very gullible, huh? All right. I can use this in the future. Okay. All right. And also the cytoplasm tends to look also cyanophilic, but a little bit more dense and homogeneous. It may have endoplasmic, ectoplasmic differentiation reflecting keratinization. And the cells usually are more isolated rather than in loose sheet-like or crowded syncytial-like tissue fragments. So remember, the reserve cells tend to form groups, and sometimes they can be syncytial, but sometimes they'll be loose and a little flatter. But here you can see groups, but they tend to be looser, and then you'll start to see more single cells. Okay. All right, here's some examples, smaller groups of these cells. Again, notice how these cells, they're round primarily. They're starting to look a little bit oval shaped here. It's kind of hinting towards its polygonal nature that it wants to be eventually. But they're mostly round to oval. The cytoplasm looks there's a little bit more, especially on this one. It's starting to look a little denser in appearance than the reserve cells. The nuclei, though, are just the same size as the reserve cells. And here's another example, different stain, and again, comparing these, and we saw this earlier as well, compare these to your size reference, your intermediate squamous cell, and you see these nuclei are definitely bigger. Remember, these are 50 square microns, these are 35 square microns. And these cells are looking round to slightly polygonal. They're a little looser. They have denser basophilia to their cytoplasm. So again, reflecting that they're starting to be keratinization. And it's an immature, an early keratinization, but it's starting to happen. And as these cells start to become more mature, they start to get a little bit more cytoplasm, a little bit more squamous appearance to the cytoplasm, and that's what makes them more mature squamous metaplastic cells. So I think that you guys should actually be able to distinguish immature from mature squamous metaplasia, don't you? Yeah, I know. Okay. Here's another example of immature squamous metaplasia. Again, they almost look like reserve cells to me, to be honest. Although, actually, I think there are some reserve cells here, and I'm telling you that because I think some of these, I think there may be a few reserve cells in here. But these other cells here, see these here, and here, and here, and here, and here, those are all metaplastic squamous cells. Here's another one. So this is a nice contrast between what looks more like reserve cell, like this one right here for sure, and this one that's got more cytoplasm. I think it's a nice contrast between reserve cells and immature squamous metaplasia. And there's some of these cells out to the edge here are starting to look like squamous metaplasia just because of the way they're starting to appear. They have this kind of a little bit of a polygonal shape to them, this little tail of cytoplasm that they sometimes get. And the cytoplasm looks a little darker. So in essence, what we're seeing is kind of a various transitions between the most immature reserve cells to immature squamous metaplasia to really mature squamous metaplasia. Okay, so we're seeing, actually, I think we're seeing all three types here. But I think it's important to recognize that these are, especially these, you're going to recognize these very well, that these are squamous metaplastic cells. All right, the mature squamous metaplastic cell, the size, shape, and chromasia are identical to squamous metaplasia in general, but I actually find that they tend to have a little bit more cytoplasm. The nuclei actually starts to decrease in size, and that's probably why it seems like they have more cytoplasm, because actually the nucleus starts to decrease from 50 to 35. Because remember, the most immature form nucleus is going to resemble most the endocervical nucleus. Okay, as they become more mature, the nucleus tends to shrink in size, and will then to proceed to the size of what an intermediate squamous cell is at 35 square microns. And again, nuclei are not observed. And note again that the most fully mature squamous metaplasia really cannot be distinguished from normal, native, mature squamous epithelium. And so when we're actually referring, as we discussed earlier, to mature squamous metaplastic cells, we're really referring to those that aren't quite fully mature. Okay? Okay. All right, the mature squamous metaplasia cell, the cell size are in this instance, actually are a little bit bigger at 640 square micron. There's more cytoplasm than the immature. They tend to, instead of nice and round, they tend to get more polygonal in shape. The cytoplasm is generally cyanophilic, and the density, it's interesting how they note here, and the density is somewhat less than immature squamous metaplasia, but I think that is partly due to the reason of the amount of cytoplasm being present, and that some of the cytoplasm in the more mature cells will actually start to show some degenerative changes and some vacuolization, which can actually make it look a little less dense. Okay, you'll see some examples of that in just a moment. But the squamous differentiation is quite evident. Now, one thing that these mature squamous cells like to do, especially when they're forcibly removed from the epithelium, removing cells from the epithelium is kind of a traumatic event for them. Okay, I know and it's not that it's, it doesn't, it's not that it hurts or anything, but it's traumatic to the overlying, to the epithelium to be pulled from its tissues. And these metaplastic cells, especially in conventional smears, more so in conventional smears rather than liquid-based cytology, really like to retain their connections with each other. It's like they're trying to reach out to their friends. And so you'll often see these little projections of cytoplasm where they used to be connected to their friends, okay, the desmosome. So you'll tend to see these little finger-like projections, and sometimes they'll form these streams or these sheets that resemble spider cells because they look like they have little, spider legs coming out of their cells. And so we call them spider cells. And this is generally often seen in conventional smears. Thin prep tends to lose that appearance a little bit, and you'll understand later. Here's some examples of mature squamous metaplasia. Again, here's your mature intermediate cell for comparison. Here's your mature squamous metaplastic cells over here. Here's another mature intermediate squamous cell. And then, again, you notice how these cells are rounder and smaller than the mature squamous cell. They do have a polygonal look to them. In other words, the borders look kind of puzzle-like. The cytoplasm is dense. It's uniform. The nuclei are centrally placed. The nucleus is probably slightly bigger than the intermediate squamous cells here, slightly bigger, but smaller than an immature squamous metaplasia. Remember, they go from 50 down, eventually down to 35 square microns when they become the most mature. Here's another example. Now here the cytoplasm is very dense, and that's a good squamous feature to the cytoplasm. Some of them are multinucleated, which they can do. They can occasionally be multinucleated. Here you start to see some projections off of the cytoplasm. The nucleus, again, is uniform throughout, and except for, obviously the ones that are multinucleated, it's a little bit different, but still the chromatin is regular. There's indistinct nucleoli. And this is another good example of squamous metaplasia. And here's another one. Again, notice how these cells are polygonal shaped. They're in a loose group. That you can make out their cell borders pretty well. The nuclei, as you would expect, are centrally placed. The chromatin is regular, indistinct nucleoli. And again, you notice the nuclear size is just slightly bigger than the neutrophil, which can also be used as the 35 square micron size reference. Now this is the example of the spider cells I was telling you about. You see what I mean? They look like they have little spider legs coming off of them. And again, this is just a reflection of metaplastic cells being pulled forcibly from the epithelial surface, and they're just trying to keep connections with their buddies there. Here's another example of squamous metaplastic cells. You can really make out their cell borders pretty well. The cytoplasm is relatively dense, as indicative of its squamous differentiation. Nuclei are round to oval, centrally placed, uniform, and just slightly bigger than the neutrophils here. The importance about squamous metaplasia is that you need to be able to distinguish them from dysplastic cells. Now, obviously, you can't do that right at the moment, but you will very soon. You don't want to mistake them. You have to be able to recognize these cells as being normal and not call them abnormal. All right. And the thing is that dysplasia can also involve metaplastic cells. So the key here is looking at the nuclear changes, and then this is something you're going to learn quite well in the next module. The most important thing to focus on is the nuclear changes. When you're dealing with dysplasia and malignancy, it's what's going on with the nucleus that is going to tell you what's going on with that overall cell. All right, what about HK and PK? Again, remember, hyperkeratosis is a cellular layer of keratin material on the surface of the squamous epithelium. It provides additional protection. PK is when there's nuclei within that keratin layer. Usually it looks like white epithelium or leukoplakia, can be seen in examples of uterine prolapse. It's a protective mechanism. Hyperkeratosis on cytology is primarily represented by the presence of numerous enucleated squamous cells. In other words, you'll see the intact squamous cell without the nucleus. And the nucleus, where the nucleus used to be, will be this little pale area. So you can actually tell, you can actually see the cell and say, oh, gosh, this little pale central area represents where the nucleus used to be. It usually involves the most mature squamous cells, such as the intermediate or the superficial squamous cell. So they do tend to retain a polygonal shape like the mature squamous cell. But they do also tend to become, because they're undergoing degeneration, losing the nucleus is a degenerative change, basically. They often stain eosinophilic and orange to yellow, but that's a combination of things that causes that, the degeneration as well as the hyperkeratinization, which will cause the cells to look eosinophilic and look like pumpkin orange colors in some cases. They may also contain granules of keratohyalin material, which is also a form of hyperkeratinization. Okay, here's some examples. Again, notice how these cells really do stand out as eosinophilic, pumpkin orange in color. But as you look at the individual cells, you can still see that they look like superficial squamous cells would as far as their shape and size, but they don't have a nucleus. Okay, you can actually see just barely right here, and a little bit over here, and a little bit here and here. You see there's a little pale area that represents where the nucleus used to be. And so this is a good example of hyperkeratosis. They do like to clump together, as you see here and here. So you often see them clump like that. So anucleate squames, basically, is indicative of hyperkeratosis. Here's another example, big clump of them. And again, all you see is just a bunch of eosinophilic cytoplasm. A couple of them have some retained nuclei, but most of them have lost their nuclei. So this is hyperkeratosis. What about PK? Again, as we mentioned earlier, it can exist by itself or in association with hyperkeratosis. These tend to be isolated cells that are quite small. They can also occur in small sheet-like, almost like little mini biopsy tissue fragments, depending on how the smear was obtained. But basically, they're miniaturized superficial squamous cells. So they're small, they tend to be round, with much less cytoplasm than a mature squamous cell, but it's very bright orange. So they tend to be brightly eosinophilic. The nuclei are small, pycnotic, hyperchromatic, and comparable to the size and appearance of the nucleus in a superficial squamous cell. So in contrast to normal superficial squamous cells, these cells are small, round, with very brightly eosinophilic cytoplasm, but the nucleus is the same. So again, almost a Halloween pumpkin orange appearance to the eosinophilia, and relatively small cells that tend to be isolated or show up in these mini tissue fragments. Here's an example. Now again, these here happen to be clustering together. These are a little bit more adhesive. But again, they look like squamous cells. They're just smaller than normal. These have a little bit of a polygonal shape to them, which you can see. I highlighted round earlier. They do tend to be round, but they can also have a little bit of a polygonal shape. Otherwise, their nucleus resembles that of a normal superficial squamous cell. Here's another example. There's a lot of degenerative changes in the background here, but you see these cells here? Very round, brightly orange, centrally placed, dark, pycnotic nuclei. These are also indicative of parakeratotic cells and the more common appearance. Here, it's actually, they're showing up as a little mini tissue fragment, and some of the nuclei are a little bit elongated here because of the streaming effect on this fragment. But it's still an example of a tissue fragment of PK showing up on cytology. And what is the significance? As we talked about this earlier, it's usually not significant clinically, but the thing is that they may mask an underlying abnormality, and persistence may warrant further follow-up, like a colpo exam or a biopsy if it continues. And you have to remember that sometimes patients with underlying HPV infection may have surface HK and PK, And in fact, it's quite common. So it's really a clue, if you see it, to make sure there aren't other abnormal cells present. And the last thing that we're going to look at from the cytology perspective here is vaginal adenosis. Again, I mentioned to you earlier that adenosis in the vagina, adenosis refers to glandular proliferation. I forgot to mention that earlier. So what we're seeing here is normal appearing glandular cells on a vaginal smear, which you wouldn't expect to see. Remember, normal vaginal smears should just show normal mature squamous cells. But what if you get someone and you're sure that the patient does not have a cervix? You know, that's always a question you got to ask initially. Did they tell me the right thing? You know, sometimes the clinicians don't tell us the right thing, okay? Or they don't fill out the history and tell us. Sometimes they even tell us that, you know, even though they did a vaginal smear, they'll put the order in CHCS as a cervical smear. That happens not infrequently, okay? Or whoever's assisting them in their clinic doing these order entries. This way, it's so important to make sure they put the right orders in. You know, because I know we've gotten a number of times where we've gotten, you know, or it'll come down as a vaginal smear, and actually we see all these endocervical cells everywhere, and we say, well, gosh, that you told us it was a vaginal smear, and we're seeing all these glandular cells that shouldn't be there. And so how do we know it's not just normal cervix versus the adenosis of the vagina if we're getting these mixed messages? So we actually have a way to handle that. We actually have a message that, or a report that we can use that addresses that. But if we know for sure the patient has no cervix, okay, from a prior hysterectomy, and all they are sampling is the vagina, and you get what look like endocervical cells on the vagina, or cells that look like squamous metaplastic cells, that's indicative of vaginal adenosis. Because should we normally see metaplastic cells on a vaginal smear? No. Because remember, they represent transformation of glandular cells. Here's the histology I showed you earlier. Again, normal, what look like endocervical type glandular cells in the stroma here, which were probably at one time connecting to the surface here. Here's what it looks like on higher power. Again, normal endocervical glandular cells, type endocervical glandular cells. I actually didn't have a picture inside on. I'm sorry. Well, we showed one earlier. If you recall, we actually showed a picture of some endocervical-looking glandulars. Basically, it just looks like normal endocervical glandular cells. If that's what you're seeing on the, if you know it's a vaginal smear. I have to make sure I add a picture. All right. Any questions on that? All right. Very good. I think we should probably go on to the next one, don't you? What do you think? You okay with that? All right. Let's see. Do I escape? Right click?
Right click.
Okay.
And show.
And show. Okay. And then this one. Okay. Yeah. I'll just leave the, okay to just leave the recording going. Okay. So now we're going to go on to SZCY 0503. Tissue response to inflammation and repair. Now we're going to be addressing the cytology of this on Monday, along with the infectious agents that cause a lot of inflammation and repair. But today we're just kind of focusing in on some very general categories of inflammation and repair that actually apply throughout the body, not just the cervix. All right, just some very general things about inflammation from the older terms from, early medical literature. Cornelius Celsus, who was from Rome, described inflammation as having four main features: rubor, tumor, calor, and dolor. Rubor standing for redness, tumor causing swelling, calor referring to heat, and dolor referring to pain. So it's just a very general description of what inflammation can cause clinically. Inflammation results from some form of internal or external injury. Any form of trauma, irritation, infection, etc. will generally cause injury and result in some form of inflammation. That's a response. It's a normal response of our tissues. Causes of injury in the female genital tract include infection, and we'll go through these on Monday, radiation, trauma, pH changes in the vaginal and cervical milieu, caustic chemicals, and other disorders that are related to autoimmune or allergic reactions. And there's varying responses to the injury. Certainly some of the irreversible changes include inflammation and then degeneration, cell death, and necrosis. Now, not all inflammation results in necrosis and cell death, but it obviously can happen. And necrosis is generally the sum of changes that result from cell death in the tissue. Some other degenerative changes include the presence of cytoplasmic eosinophilia. And in fact, cells can become dead and will look entirely eosinophilic, and we refer to them sometimes as dead reds, okay? But the other thing is the nucleus will take on a ground glass appearance initially when it's dying, and then the nuclear chromatin can undergo pycnosis, lysis, and karyorrhexis, which is until it actually totally dissolves, basically. The point here is that injured cells release chemical mediators of inflammation and repair. And some of these chemicals are specific messengers. Some of them are just products that leak due to injury of the membrane, the cytoplasmic membrane. And the body recognizes these signals, and these signals then help to gather up the forces, okay? The inflammatory cells that come in, the soldiers that come in to help repair the damage. Again, not all cells that undergo this injury die, okay, but I just want you to know that, obviously cell death is a potential outcome. Okay, types of inflammation in 3 general categories: acute, chronic, and granulomatous. Now, granulomatous inflammation is actually a subtype of chronic inflammation, okay? But we're going to talk about them a little separately. Beginning with acute inflammation. Acute inflammation is generally the first response to injury, okay? It's like the Marines that come in the first response to any battle, right? Is that right? Okay. I'm trying to make this kind of like a war game, I suppose, but I'm not doing a very good job of it. But the acute inflammation is the immediate response to injury. It's usually a short duration. You tend to get primarily neutrophils as part of the leukocytic response. There's also an exudation of fluid and proteins from the tissues, causing edema. That's what causes it to form a nodule or mass. In other words, a tumorous kind of mass. Now, tumor is referring to a palpable mass, in the tissues. It doesn't necessarily mean a malignant tumor. In this case, we're referring to an inflammatory tumor, okay? Because tumor means an abnormal growth, right? Okay. Now, what are the outcomes of this acute inflammation? There's complete resolution, healing with scarring, abscess formation, progression to chronic inflammation, cell death probably should be in there too, because what can give you abscess? In abscesses you got a lot of neutrophils and dead and dying cells. So actually cell death is part of that as well. But in most cases you get complete resolution. Now, in some cases it may progress to chronic inflammation over time. But here's an example of acute inflammation in the tissue and on cytology, and here you can see this is actually, it looks like endocervical glands that are just filled and surrounded by abundant neutrophils. You should never see this many neutrophils in any of the tissues in the female genital tract. And they show up on a pap smear here as abundant neutrophils. Now, neutrophils by themselves on pap smear are not specific, okay? Remember, because you can see some neutrophils on pap smears commonly. But when you see a lot of them, so much so that they're covering the squamous cells, obscuring the squamous cells, causing reactive changes to the squamous cells that we'll talk about on Monday, that's indicative of real acute inflammation happening in that setting. So in other words, the inflammatory cells can be there, but unless they're causing a cellular response, it's really not a true inflammation. Now, what about chronic inflammation? Chronic inflammation is usually of longer duration. It can last for weeks, months, years. It's generally characterized by the presence predominantly of your mononuclear cells, your lymphocytes, your macrophages, as well as plasma cells. It often causes or is associated with the proliferation of blood vessels and connective tissue. In other words, it's almost like it's starting to want to form a scar in a way. And certainly can cause tissue destruction. Here's some examples. These are lymphocytes here on Difquick as well as over here on Pap stain. Lymphocytes tend to occur as mostly as single cells, but occasionally you'll get clumps like you do here, depending on how cellular the specimen is. But if you make out, there are some squamous cells here in the background, but the lymphocytes here tend to be single cells that are small with high NC ratio and dark chromatin. Here they are on Difquick. You're not used to seeing Difquick yet, but that's what they look like on Difquick. And again, it's a discohesive population of small monotonous cells with very scanty cytoplasm. And here are actually what type of cell? Anyone want to tell me what type of cell that is? What's that? Those are plasma cells. Of course, you know, the little P there probably, no. Well, it could be P for PMNs, right? Okay. But anyways, these are plasma cells because of why? What's that? Clock face chromatin, what else? Eccentric nucleus, yes, who said that? Okay. The students, right, should be answering. Okay. Clock face. Eccentric nucleus. What else can you see in plasma cells on cytology? What's that? Yeah, what's that called? Hopf zone. There you go. Very good. Excellent. And what makes up the Hopf zone? Why has it got that appearance? What is it comprised of? Anyone? What organelle? You got to, what? Golgi apparatus, yes. Very good. You guys are, yeah, see, you remember. Okay. Anyways, plasma cells form immunoglobulins, and they kind of come in for certain types of responses, okay? All right, chronic inflammation arises in three ways. It's generally following a bout of acute inflammation, following repeated episodes of acute inflammation. It may begin insidiously as a smoldering response to some chronic injury. You may not necessarily have an initial acute inflammatory response in that setting. Again, okay, I mentioned earlier about granulomatous inflammation is actually considered a subset of chronic inflammation. It's characterized by collections of macrophages that are referred to as epithelioid. You know, have you heard that term before? Epithelioid, what does that mean? Anyone? What does it mean to be epithelioid? Are macrophages epithelial? No. Okay, so macrophages are not an epithelial cell. They are a type of leukocyte, okay? But in some cases, macrophages will take on an appearance that resembles an epithelial cell. So in other words, when you are epithelioid, that means you resemble an epithelial cell, but you are not, okay? So it's actually a descriptive term, in other words. I know, it's hard to imagine that we can use that as a descriptive term, but we do. So in other words, these macrophages tend to have abundant pale cytoplasm with only a single, usually, but they can have occasional multinucleation as well, but primarily a single oval-shaped nucleus surrounded by these abundant pale cytoplasm that kind of resembles a epithelial cell, a squamous cell, for instance, except it's usually, the cytoplasm is usually a little bit paler than a squamous cell. So these aggregates of these types of macrophages tend to be associated with some lymphocytes that are often at the periphery, but scattered throughout. And when you get these collections of these macrophages and lymphocytes, that's referred to as a granuloma. Okay, and that's what really defines a granuloma, is these epithelioid histiocytes with lymphocytes. You may have some multinucleated giant cells in the background, but remember, these are rather nonspecific cells by themselves, because you can see multinucleated giant cells in a number of things, but they are a type of macrophage, obviously, the multinucleated giant cells in this setting. They're just different than the epithelioid ones. They're multinucleated. The nuclei tend to be rounder and darker. They often have engulfed cellular debris within them, whereas actually the epithelioid macrophages don't tend to be phagocytic. The multinucleated ones do. All right, and again, granulomatous inflammation can be seen in a number of inflammatory conditions, to include more common things such as tuberculosis, sarcoidosis, leprosy, fungal infections, and some other infectious conditions. All right, so here's an example of a granuloma on histology. In the background here, you've got this peripheral rim of small blue lymphocytes. All right, and then the center area is a pale aggregate of epithelioid histiocytes. They have abundant pale cytoplasm, central to eccentrically placed, elongated, oval-shaped nuclei. Sometimes they have little bends in them, like you see here. They can sometimes take on a little bit what we call a reniform appearance, like this one, where it resembles, what does reniform mean? Kidney bean shaped. And see, doesn't that one look like a kidney bean? Yeah. All right. They have indistinct nucleoli here that you can make out, but they're not hugely prominent. And they're associated with these, again, notice their abundant pale cytoplasm. Again, when they aggregate together like this, they stick together along with the lymphocytes. That whole structure there, from here, from all around here, this whole thing is called a granuloma. Okay? All right, a little bit about the cell mediators of inflammation. Again, what kind of cells do we see here predominantly? PMNs. So we got lots of PMNs obscuring the underlying squamous cells, maybe causing some reactive and degenerative changes. So definitely got an acute inflammatory process going on here for whatever reason. The neutrophils, as I mentioned, as you know already, are polylobated. Are 10 to 12 microns in diameter, engulf microorganisms and foreign material. They originate originally from the bone marrow, so they're part of the myeloid cell population, which include the myeloid cell population not only includes the neutrophils, but also eosinophils and basophils. Macrophages are also chronic inflammatory cells. They originate from blood monocytes, which come from the bone marrow. They tend to be phagocytic. They contain many enzymes which destroy microorganisms. Here's some examples. This is interesting because this is actually a multinucleated giant cell, which has actually ingested a degenerating squamous cell. Okay? So there's actually a squame ingested in the cytoplasm of this multinucleated histiocyte. That's interesting. Huh? And then, of course, here's another multinucleated histiocyte. Again, notice all the nuclei throughout that are small and dark and regular, the pale cytoplasm. You've seen these cells before. And they are nonspecific because they can be seen in a number of conditions, can be seen postpartum, postmenopausally, patients who've had surgery, radiation, any number of things. So if you see this on a Pap test, I think it's important to note its presence in your mind, but if you only see a few isolated ones, it really doesn't mean anything clinically, unless you had aggregates of epithelioid histiocytes forming a granuloma. Then that would mean something, okay? There's a difference. What about lymphocytes? These are our main chronic inflammatory cells, mediators of immunity and immune responses. We have both the T and B lymphocytes. T are responsible for cell-mediated immunity responses, where B cells are part of the humoral immunity responses, and they're the ones that form the antibodies necessary for responding to a number of infections and other conditions. So we got our T and B cells. We'll learn much more about this later on, especially next year when we do our non-gyn lymphoid units. So, oh yes, what an interesting. I have to thank Mr. Franco for including this image, I guess. All right. It's pointing out to apparently here T cell. Okay. All right, Mr. T. Okay. All right. Well, the poor T cell is out of work, I guess. All right. All right. One of the things that the lymphocytes can do in the cervix is cause a disorder called follicular cervicitis. It's a type of inflammatory condition that can be seen, and we'll talk more about this on Monday. But this is actually showing you a good example of follicular cervicitis, showing you abundant small mature lymphocytes, and then these scattered macrophages here. Do you see right here? These are actually these cells here with the cell debris within their cytoplasm are actually macrophages. And their presence along with the lymphocytes in the background is indicative of sampling of a lymphoid follicle that you see in a number of reactive lymphoid hyperplasias. And so that's a good clue to the presence of a type of cervicitis known as follicular cervicitis, and follicular referring to the prominent lymphoid follicles that occur in the setting of this type of cervicitis. What about some of the other cells, like the eos, basos, mast cells, plasma cells? Eos are bilobed inflammatory cells with abundant red granules in their cytoplasm, and in these granules are enzymes which help to mediate certain types of inflammation. They are primarily associated with allergic reactions and some other immune reactions. Allergic reactions to a number of things, fungi, parasites, non-specific things, but anything that can cause an allergic reaction, you tend to see a lot of eos with. Basophils are uncommon. We see them uncommonly, certainly in the cervical smear. They have blue granules and also participate in certain inflammatory responses. Mast cells are granulated cells that release histamine and other mediators. Histamine is also important in causing certain allergic type responses. Plasma cells, as we mentioned earlier, are basically modified lymphocytes. Plasma cells actually are a type of mature B cell, okay? And again, participate in immunoglobulin production. All right, eosinophils are actually hard to make out on Pap stain. You know, the one thing, because you don't see the eosinophilic granules as well on Pap stain. The eosinophilic granules that make up eosinophils are best seen on your right Ginza preparations, like you got in your hematology labs, and on H&E preparations. So, but you can still tell when you have EOs on a Pap stain. You have to pay attention to the fact, like this is an EO right here. Here's one right here. Here's another one there. What you appreciate on the Pap stain is the bilobed nucleus, okay? Whereas over here on H&E, you can definitely see the eosinophilic granules here and over here. So a good example of EOs. Plasma cells, again, nice picture with the clock-faced chromatin, the eccentric nuclear placement, the Hoff zones. Okay, let's see, where are we on this? Well, we still have about another 20 slides to go. What do you think? Do you guys want to take a break, or do you just want to move on? You don't want to keep going? Everyone's okay with that? Okay, all right. All right, patterns of inflammation in general include, this is actually applies to mostly fluids, and we'll learn more about this when we do the effusion cytology in the next block. But exudate, transidate, edema. Exudate is an extravasated fluid that's very high in protein, has a very high specific gravity, greater than 1.020. A transidate has low protein, mostly albumin. It's a clearer looking fluid, and it has a specific gravity less than 1.0. That should be 20, I think. Okay. And then edema, so what does it say in your handout? Oh, it says 1.012. All right, well, we'll just leave it as is, but I think it's supposed to be 20. I could be wrong. The edema is fluid that occurs in tissue or cavities. And again, fluid occurring in tissue or cavities, such as the pleural cavity, can either be a transidate or an exudate. And again, we'll learn more about this as we go on in the year. Now, there are different patterns of inflammation. Serous inflammation is an outpouring of thin fluid, vascular versus excreted by the cells. Fibrinous, you get an exudation of many proteins, including fibrinogen, resulting in clotting or precipitation. It's basically, fibrin refers to clot formation, okay? And this type of inflammation is characteristic of certain conditions. You can get what's called a fibrinous pleuritis or pericarditis, which is associated with a lot of clotting. And then one other type is referred to as suppurative or purulent inflammation. This basically refers to an abscess being formed, and you get a lot of pus, and pus is formed of many neutrophils and cellular debris. Ulcer is where you get an ulceration of an epithelial or mucosal surface, and what happens when an epithelial surface is ulcerated, you lose epithelium in focal areas or large areas. And so basically you lose the epithelium, and they're exposed to the environment is just unaligned connective tissue, and that's not good. And that tends to be associated in its early stages with a lot of inflammation in response to that loss of the epithelium. Because remember, without the epithelium, the tissue doesn't have its protective mechanisms anymore, so that tends to cause a lot of inflammation. But the ulcer itself is just loss of the epithelial layer in that area. All right, what about healing and repair? Obviously, in response to inflammation, there's going to be healing and reparative changes, regeneration, that's going to respond to the inflammatory conditions. Regeneration refers to replacement of the injured tissue by cells of the same type. And there's three types of cells. There's those that are labile, others that are stable, and others that are permanent. So in other words, labile cells, or labile, actually is a better way to pronounce it, are highly proliferative cells and easily replace and easily regenerate after an injury. Stable cells are able to regenerate, but not to the same degree as the labile cells. Permanent cells cannot regenerate. So if they've been injured, they don't get replaced, okay? I guess I can think of it as one type of cell that's been in the news recently is patients who get partial liver transplants. Did you know that the hepatocytes can regenerate to a large degree? And so when they get only a part of a liver, some of the liver tissue will expand and regenerate because those cells are able to regenerate. So I thought that's kind of interesting. All right, what about repair? Again, repair refers to replacement of damaged or dead cells by healthy cells and tissue. It can be characterized by regeneration of the same cell types or replacement by scarring tissue. In other words, connective scar tissue can replace the damaged cells. And scar tissue is very permanent type tissue. It doesn't often, once you get scarring, it doesn't usually go away, okay? It can be permanent. And we're going to look a little bit about repair here, but we're actually going to discuss repair in a little bit more detail on Monday and actually show you some really good examples on cytology. But repair of cells refers, again, it's a regenerative and a reactive process. The cells tend to be they're immature, okay? They have higher NC ratio. They get prominent nucleoli. Because remember, when cells are undergoing repair and regeneration, they're very active. And the chromatin is going to be very active. So it's common to see prominent nucleoli. They also are going to have mitoses, okay? But unlike dysplastic or malignant cells, that are of concern, they will retain smooth membranes to the nuclei and well-dispersed chromatin. Okay, so it is important to be able to understand these differences so you don't mix them up with a true atypias, dysplasias, and cancers. All right, so here's an example, a couple examples of repair, both on low and high power. Here's a sheet of what look like metaplastic type squamous cells, right? Okay, and they're actually showing nuclear enlargement. But they're not overlapping each other. They're kind of minding their own spaces. You can still make out some cell borders. It looks like the cells, nuclei, and the cells themselves are kind of streaming in one direction here, and that's a feature of repair. But the nuclei are enlarged. They have prominent nucleoli. The chromatin otherwise looks uniformly placed and kind of pale. There may be an occasional mitosis, although I don't see one in here, but this is very typical for repair. Flat, streaming sheet, cells with enlarged nuclei, and prominent nucleoli. Okay, those are metaplastic squamous cells here that have undergone repair in response to some kind of external stimulus. Now here it is on higher power to show you again the nuclei that are enlarged, compared, prominent nucleoli, but smooth nuclear membrane borders, and even chromatin distribution, which are all normal findings, okay? All right, now just to give you a little hint here, a little preview. Okay, one of these is repair, one is malignant. Which one is which? What was that? Which one is that on the left? Is that repair or carcinoma?
Carcinoma.
Okay, who? Raise your hand if you think the left is repair. Don't be shy. All right, so half of you, okay. So that means the rest of you think that one's the cancer, right? Okay. Well, that's wrong if you thought it was cancer, okay? Because actually the left one is repair, the right one is cancer. And you're thinking, how do I know that? Well, first of all, if you look at these, notice how these nuclei are these cells have abundant cytoplasm, which is a good finding, okay? The nuclei are not showing that much overlapping. If you look at each nucleus, even though they're enlarged, they still look very uniform. The chromatin distribution is uniform. There are occasional nucleoli, which I would expect to see, and you see good cell borders. And it looks like they're streaming in kind of one, they're maintaining a polarity with each other. But whereas you look at this group over here, yes, the nuclei are enlarged, but look at the chromatin and the membranes are very irregular. The chromatin is very irregularly distributed. There's multiple nucleoli. Again, the nucleoli that are typically seen in repair, there's usually only one, okay? Here, there's multiple nucleoli, chromatin irregularities. They look pleomorphic. They don't look uniform. They're not showing the streaming anymore. They have higher NC ratio. They have atypical mitoses, okay? Yes, mites can be seen in repair, but they're not going to look this atypical. All right, so all of those things, and believe me, this is just a little preview because you're going to learn these differences over and over again in the next couple modules. Okay? Okay, a little bit more about inflammation and injury specific to the cervical canal. Again, when there is some type of injury or inflammation, initially there may be superficial destruction, there may be complete loss of the epithelium, which causes ulceration, and then you may get, after that, you will get regeneration and repair. Now, when the epithelium is ulcerated and gone, or denuded, as we call it, the epithelium will regenerate. Okay, you need to have some kind of epithelium there. It's going to regenerate. And the regenerative epithelium may show some features of repair. All right, here's some examples of inflammation affecting the cervix. First of all, this is the ectocervical tissue. Here's endocervical tissue. So actually there's a little bit of an ectropion here too, okay? But I can't make out the os here because the os is filled with all this discharge, which you can also see with inflammation or some type of infectious agent. And we'll talk more about the infectious agents on Monday. But again, there's definitely something happening here. The endocervical tissue looks a little redder than normal. That, when inflammation occurs, you tend to get increased vascularity, so it's not uncommon to see the redness, some edema. So you get increased fluid, you get discharge because of the increased fluid. Okay, so all of that goes along with the inflammatory process. Now here it is on histology. Here you've got squamous epithelium here that looks relatively normal. But over here in the stroma, you've got all these inflammatory cells that look predominantly to be chronic, looks like lymphocytes predominantly. And then you've got all this blood, okay? And you've got extravasated blood, both in the underlying stroma as well as in the epithelium. And this also is, and the reason that occurred is because notice this epithelium over here is normal looking, and over here it's very thin. And so what's happened is there's an ulceration has occurred. It's not, the epithelium is not completely absent here, but it's definitely thinner than normal. So some type of ulceration has occurred, and that's why we're seeing all this inflammation. But eventually this epithelium will regenerate and go back to its normal thickness over time. Okay, but in that time period, the cells that are there are going to show reactive changes, okay? All right, different cellular reactions to different agents, and again, you can get reactions to a number of conditions, include a patient who's had a prior biopsy, someone who's had cautery therapy, cryosurgery, chemotherapy, whether it's topical or intravenous or by mouth. Other chemical agents that can be applied to the cervix, and certainly some immunosuppressive agents can all cause reactions to cells. And we're actually going to talk about cellular reactions like this, the chemo, the cryo, etc., towards the end of Block 8, but this is just a little mini introduction. All right, so here's a cervical biopsy that's being done. When they do a biopsy, they take a little punch of the cervical tissue using these types of devices here, viewing the cervix generally through a colposcope and a speculum. But these, you see, they just take these little snips of tissue. Doesn't look that little here though, but I tell you, they really are little when we get them. Now, those biopsy sites will undergo repair and regeneration. They usually heal within 2 to 3 weeks. It's best not, after a patient who's had a biopsy or a LEEP excision procedure, it's better that they don't get any additional sampling for several weeks, 4 to 6 weeks if at all possible, because of all the reactive changes that can occur during this regeneration, okay? So indeed, if you sample too soon after a biopsy or a LEEP, you're going to see a lot of reparative changes, a lot of inflammation. It can start to look atypical, and you have to wonder if there isn't something else going on. But it's best to wait until they've healed. It's 4 to 6 weeks. Same thing with patients who undergo cautery therapy, where they apply hot probes to treat areas or excise lesions. This looks like some scary movie here. I don't know. All right. That looks bad. Okay, and electrocautery is used for can be used for benign lesions, but not very commonly. Most often, it's used for treating It can be used for treating dysplasias. The cautery is also a part of the process of what's used during LEEP excisions. But it basically causes burning of the epithelium, so you tend to get what's called cautery artifact by these hot probes. Cautery artifact in the cells can cause some changes that are quite unique. And again, we're going to learn about that a little bit more later on in this block. Here's an example of a patient. They don't do, believe it or not, they actually don't do cryosurgery very often anymore in the cervix, but some places do. They don't do it very often here. Basically, it's where you apply liquid nitrogen to a lesion, and it burns it off, basically. It doesn't sound very pleasant to me, actually. I don't think, actually, they don't like to do it because actually it does cause a lot of discomfort and symptoms for the patients, so they don't really do this too much anymore. If you've ever gone in for a skin lesion and they take out the liquid, it's kind of the same concept where they spray it off with a liquid nitrogen. It basically causes it to die. It freezes it and it eventually dies and sloughs off. But if you can imagine that happening to the cervix, I don't know. Doesn't sound very pleasant, does it? So again, it's a cryoprobe, and it does help to treat isolated lesions. And in some patients, that may be the only way they can treat multiple lesions of the vagina, for instance, because you can't go in and do a leap of the vagina, right? And patients do get dysplasias in the vagina, and so sometimes the best way to treat them is by cryotherapy. But usually when they do that, they put the patients to sleep. Okay, and that's a good thing. That would be a good thing. Again, cryosurgery causes freezing. It can be used on benign inflammatory lesions, but not really very often. And it's more often when it's used on dysplastic lesions. It causes a lot of cellular degeneration, inflammation, repair, especially karyorrhexis. And again, the same thing as with the biopsies and the electrocautery that heats the tissue. You don't want to sample too soon. You want to wait several weeks after a patient has had such procedures before you do any other resampling because of all the reactive and regenerative and degenerative changes that occur. Now, what about systemic chemotherapy? In other words, patients who are getting either oral or intravenous chemotherapy, even though it's not being applied to, the female genital tract, as we're talking about this right now, you can actually get secondary effects in tissues throughout your body from systemic chemotherapy, and you may actually see changes on the cells in the cervix from this. So it's important to know this history, okay? Because different agents, and you want to know what type of chemotherapy they're getting, because different types of chemo can cause different changes to the cells. And there can often be nuclear atypia, and you have to be wary of that to make sure you don't overcall something dysplastic or neoplastic. So the history is very important. You need to know if a patient is getting chemo or radiation therapy. Immunosuppressive agents are used in autoimmune disease and transplant patients. Actually, patients on immunosuppressive agents are not only at risk for infections, opportunistic infections, but they're also at risk for accelerating their dysplastic and neoplastic changes. For instance, an example is patients who are HIV positive. Any patient who's HIV positive is considered immunosuppressed. Women who are HIV positive tend to get worse changes in response to HPV exposure. In other words, the dysplasias that they get tend to be higher grade, more progressive, so they actually have to be treated more aggressively when they get dysplasias because of the underlying associations. Radiation exposure causes damage to cells throughout the body, and primarily focused on the areas that the radiation beams are going towards, but this is an example of a patient getting radiation to the breast after a lumpectomy for breast cancer. And again, you can get effects on all the tissues in the background. And so that's why it's very important that the radiation therapists guide the beams to the right location and provide the absolute maximum amount of radiation that they can apply, nothing more, okay? Because if you go beyond a certain level of radiation exposure, it can be damaging to the normal tissues. And radiation effect, again, we're going to talk more about this at the end of Module 8. But radiation can cause a number of changes, and it also depends upon whether it's an acute stage or a chronic stage, or whether it's many years after a patient received radiation. But acute radiation effect, the cells tend to become quite large, so you get increased cell size, vacuoles in the cytoplasm, vacuoles in the nuclei too, polychromasia, bizarre cells, and huge nucleoli. These are highly regenerative changes, okay? But the acute changes are usually brief. Chronic can persist. You can have persistent large or macrocytes, as we call them, some with bizarre shapes, can persist for many years after radiation has been received. And then patients who receive radiation to the female genital tract can actually develop months to years later dysplasia, totally unrelated to the reason why they had the initial radiation therapy, okay? What if they were getting radiation for treatment of cervical cancer, which most often is caused by HPV, okay? And we'll talk about that too very soon. But the radiation, the patients who get cervical cancer, many of them are going to be treated with radiation to the cervix, to the pelvic organs. These same patients can then develop 10 or 20 years later dysplasia that's not at all related to their HPV. It's related to the fact they had prior radiation. Doesn't happen very often, but it is something to be wary of, and it's why patients who've received have gotten radical hysterectomies, radiation treatment, chemotherapy, are followed every year thereafter for the rest of their lives for the possibility of either recurrences of their cancer or new lesions like post-radiation dysplasia. And I think that's the last one. It is. So, that's it. Any questions? See, I even finished before the end of the time. Yay. No. So we all go to early lunch, right? Maybe. Huh? All right. So I'll see you then on Monday morning. Probably, see, since I have to go to the MC morning report again, okay, which is fine. That's part of my other job. There is a possibility I won't be able to get here till 9 o'clock again. If that works for all of you? 9 o'clock, Monday. All right, very good. I didn't stop the recording now. Right here, right? Or this one?